So the main purpose of this talk is about audiologist-delivered cognitive behavioral therapy for hyperacusis and also misophonia. And so the therapy for sound intolerance in general, whether it is hyperacusis, misophonia, or general noise sensitivity, it also applies to tinnitus as well. The main framework of the cognitive behavior therapy is very similar in these conditions. And so there are some key aims that people who engage in these therapies need to achieve. One of them is to learn about their condition, and I'm sure that audiologists are in a very good place to teach their patients about the causes, possible causes and mechanism of tinnitus and hyperacusis. And by listening to the talk of Professor Salvi today, you are in even a better position to explain for your patients what are the possible mechanism for hyperacusis. The second aim, long-term aim that you as the therapist needs to have for your patients, that they need to be cooperating with medical, psychological, and rehabilitative treatments offered to them by other professionals, because people who come to your clinic for help with hyperacusis or misophonia is very likely that they are seeing other professionals as well, to help them with whether their mental health or some other hearing, balance problem, medical conditions. And so it is important that during the course of the treatment, keep an eye on whether they are adhering to the advices that other professionals have given to them. And the third aim is the important one. They need to learn and implement CBT skills. The fourth aim is they need to develop a confidence in being able to carry out their day-to-day tasks, to be able to rest and relax and enjoy their life, even when hearing the trigger sounds or the noises that bother them, without the need for avoidance behaviors. And this is a very key goal in the therapy, that also in the previous talk you heard of avoidance hyperacusis as well as loudness hyperacusis. So avoidance of the noise itself is it's problematic, and during the CBT they need to learn to be able to basically live their normal life and enjoy their normal life despite hearing these trigger sounds and without the need for avoidance. They also need to develop a skill for dealing with setbacks. Setbacks are inevitable and they will happen. So it is just a matter of when. And so they need to be prepared to dealing with setbacks. And this is one key skill that they need to learn during cognitive behavioral therapy for misophonia and tinnitus. The worst thing that they can put their mind in is that try to avoid changes or re-triggering in their hyperacusis or misophonia. Many people can start isolating themselves in the fear that if they are outside and they hear a loud noise, it re-triggers their hyperacusis, or it can cause further problems for them. But this is an aim, which is an instinctive reaction of the person, but is not very feasible because first of all, there are so many factors that can impact on creating a setback with misophonia and hyperacusis that we even do not know, because we do not fully understand these conditions. There are a lot of theoretical models, even experimental models, but we do not fully understand all of the extents of these conditions. And there will be a lot of things that we don't know which can re-trigger these problems. So it's not really feasible to avoid changes in these. And then if they want to avoid changes in these and isolate themselves, this can actually make them feel isolated, even depressed. And there are lots of research evidence that's showing that depression can actually impact on hyperacusis in a negative way and make the hyperacusis even worse. So instead of trying to avoid changes in their symptoms, they need to be prepared for those inevitable changes. And when those changes happen, instead of getting panicky and going back to their avoidance behaviors, then they need to apply the CBT skills. They need to have a plan. Okay, when this happens, how I'm going to deal with it, as opposed to thinking, oh, it will not happen, I must avoid that. So there are various models of offering CBT. And previously I talked about, in different places, I talked about a 6-session model. And in a 6-session model, in my view, is the bare minimum of number of sessions that you can have for managing, for helping a person learn skills to manage their hyperacusis or misophonia. But today I talk about a 14-session program. Usually a 14-session program, the first 10 sessions are weekly, so they have 10 therapy sessions each week, 1 therapy session each week for 10 weeks. And then after that, the final 4 sessions, the gap between the sessions increases to 2 weeks, 1 month, 3 months, and 6 months. So they'll have more opportunity for practicing their CBT skills, more opportunity for experiencing some setbacks, so they can manage those setbacks while they are still under your care. It is very difficult to actually list what will happen in each of these therapies, because you have to adjust your interventions based on readiness of your patient and where they are in the therapy. But I try to put something together here for you to get a gist of the process. So initially, the session 1, you need to build a rapport with your patient and getting to know them better. And when you're asking questions about their misophonia and hyperacusis, you need to create a model within your own notes that you are creating, that what is it that you think is creating this vicious cycle of anxiety because of noise or trigger sounds in the case of misophonia. And it is very important in that very first session to try to understand what is the goal of the patient and what is it that CBT can achieve, and create a bridge between these two things, because a lot of concepts of CBT is based on acceptance of what is happening, of their emotions, as opposed to wanting to get rid of them. And it may not be necessarily what they have in mind when they come to your clinic. The most likely is they want to eradication of all of their symptoms. That would be the aim, that they come to you. But in order to minimize those symptoms, they need to go through this path of CBT, which is very much based on the acceptance and not fighting with those symptoms. And so this is something that needs to be addressed right away from the start of the treatment. Usually in the second session, you gather certain information that you can create a cognitive behavioral formulation, which explains the mechanism in which sound can lead to distress, and distress can lead to further sound intolerance. I will talk about that in the next slides in a bit more detail, how the formulation would look like. And you need to share that formulation with the patient, so they need to understand what is it that you're working on in the CBT sessions. The other task that you need to right away start is called exposure and ritual menus. So basically you need to create a list and helping the patient to scope what are the avoidance behaviors that they may be doing, or ritualistic behaviors that they may be doing to help themselves to cope with their hyperacusis and misophonia, and help them to think why they are doing that particular behavior, what do they think will happen if they don't do it, and then how difficult it would be for them if they were going to stop that particular behavior. So you'll have a list of certain avoidance behaviors or ritualistic behaviors, why they are doing it, and how difficult is it for them to stop that particular behavior. And you will use these in the future sessions to help them to gradually, starting from the easier ones to the more difficult ones, to get rid of those avoidance behaviors and rituals. And this is the behavioral elements of the cognitive behavioral therapy. And in the next session, they learn more about what, excuse me, how CBT can help them. It's called the CBT psychoeducation. And then you introduce the idea of diary of thoughts and feelings, and which they can take notes of what different events related to hyperacusis and misophonia. For example, I hear a loud noise and it is bothering me. So what is the emotion that you're experiencing in that moment? What is the thought that goes through your mind? These are all the exercises that they do in order to become mindful of what goes through in their mind. And then you introduce a behavioral experiment framework in the which we call it SEL here, SEL model. And SEL stands for stop avoidance, expose yourself, and learn from it. So it's a very much cognitive behavioral intervention, because you stop certain behavior. So that's the behavioral part of the CBT. And then you learn from that experiment that you've done. And that is the cognitive component of CBT. I talk more about SEL in the next future slides here. And then they in the future sessions, they learn, they bring their diaries for you and you review them for them. And each time you give them a bit harder task for the SEL model. And in the sessions, you help them to explore, dig deeper in the thoughts, find out which are the thoughts that are most troublesome and linking to the anxiety that they are experiencing, giving them more information about possible errors of judgment. And the task for them is to find the errors of judgment in their own thoughts. And this is not an easy task. It is easy for you to see the errors of judgment or distortions in other people's thinking, but when you start wanting to find out the errors of judgment in your own thinking, that's a more difficult one, because if you knew what errors you have, you would have corrected them. So that's a skill that they need to learn. And then introducing counter statements, which are there to neutralize the negative thinking that they may have, getting them to this understanding that identifying the negative thoughts and how to challenge that with the counter statements. And the aim would be by session 10, you can introduce a CBT skill, which I call it KKIS. And the first K stands for know when to do your CBT. Second K is to keep on with the negative emotions, and the I to identify negative automatic thoughts, and S to substitute them with your counter statement. I talk a little bit more about KKIS in the future slides. And so a lot of follow-up sessions focuses on practicing on KKIS and see if they actually understood it and implemented it correctly. And then toward the end, you talk about setbacks and how to deal with them. And one way of dealing with them is to integrate CBT into their lifestyle, a technique that we call it CBStyle. And because when they integrate CBT into their lifestyle, then this is something that their skills will be always sharpened and up to date. And in the case of setbacks, they can right away go back to the CBT and use it, as opposed to if they not use it anymore. And in the time of the setbacks, then their skills is very rusty, and it take more time. So this is the a cognitive behavioral formulation for hyperacusis, this one. And so the trigger is the loud noises or the noises that they are bothered. And when they hear the sounds, they have an initial reaction to these sounds. And the initial reaction can have different components. They have certain emotions. They may get experience anxiety. They have certain behaviors. They may automatically cover their ear. And they may have some bodily sensations. In the case of hyperacusis, could be discomfort in their ears or even pain. And so it is important to recognize that this initial reaction is what is happening without any conscious thinking. This is probably what you were basically hearing in the in Professor Salvi's talk, is the initial reaction to the noises. So their hyperacusis in rats, I don't think goes beyond this initial reaction. Then what happens in humans? Then there is a chain of thoughts that goes through their mind, like this is a damage, there's damage in my brain, I cannot do things the way that I like to, there is no escape, I have no control, I'm trapped, I cannot lead a normal life, so on and so forth. And obviously these thoughts are different in each person. And during those CBT sessions, you have to help your patient to identify the thought process that goes through their own mind. And then these, depending on what is the thoughts that goes through their mind in that point, they will have a follow-on reaction. The follow-on reaction, again, have emotions, behaviors, and bodily sensations. So, for example, if they think there is a damage in their brain, they may get afraid. And if they think the noises are going to damage their hearing, the behavior would be that they'll start avoiding those noises, and they use ear protection, this and that. And their bodily sensations would be anxiety-related sensations. And then after that, they have more deeper thoughts, more evaluative thoughts, like I will be isolated and lonely, I am unlovable, people are not trustworthy, life is hostile. These are more core beliefs that the person may develop. And and then these will feed back to the whole model, creating this vicious cycle of anxiety, will basically lead to more focus or selective amplification of those noises and worsening of their symptoms. And in CBT, the aim is to help the person to identify the thoughts in this circle and that circle there, and then their behaviors here in the follow-on reaction, and help them to basically modify this in a way that they can break this cycle. And when the cycle is broken, the initial reaction will not get any reinforcement. Therefore, their symptoms does not get worse. In fact, when when certain reactions do not get reinforced, whether by punishment or reward, that can actually reduce over the passage of time. And this is but for each patient with hyperacusis, you need to create a custom-made model, a formulation for their treatment. This is a formulation for misophonia, and the triggers would be a different sort of sounds, and they will have different initial reaction pattern, different sort of thoughts, so on and so forth, but all will fit in this cognitive behavioral conceptualization of the distress that they are experiencing. And the aim would be, again, the same in terms of breaking this vicious cycle. So I'm conscious of time. I don't know how much more time, Sarah, how much more time I actually have?
You can have another 5 minutes.
Another 5
minutes. At the most.
That's fine. Thank you. So this is in this slide, I can show you the avoidance examples of avoidance behaviors that you need to look for in your patients with hyperacusis and misophonia, and also ritualistic behavior, so you can see the difference. So for example, the hyperacusis, overuse of ear protection and avoidance behaviors, avoid going to certain places and avoidance behavior, keep measuring the sound levels in different places. That's more of a ritualistic behavior. Or searching in the internet over and over again for a cure for this, that also can be a ritualistic behavior, because they may know that there is no reliable source of information in some of the forums that they do, but they may think, at least I'm doing something, give them some sort of a sense of control. But I put here burning a lavender oil. This was one person doing, so I thought that is probably a sort of a ritual for hyperacusis. For misophonia, avoid eating with the family, avoid spending time with the person who triggers them. These are the examples of avoidance behaviors. telling people not to make noise, knowing that it may not be feasible for them. So if you tell people to stop making the noise and you know that they will stop, then that's could be an avoidance behavior. But when you know that they can't stop breathing, and despite that you tell them to do so, then that is more going down the route of a ritualistic behavior. Just telling them something makes you feel that you actually have done something, or give the person who made the noise a look. That can happen a lot in people with misophonia. So many other avoidance behaviors and ritualistic behaviors that you must identify. You must help the patient to identify and gradually reduce during the course of the treatment. So I think I'll just give you one example of SEL. In SEL model, they need to choose what sort of avoidance behaviors they want to stop in a particular week. For example, this person, they were not using Hoover to clean their room, so they say, I'm going to use it this week. And then they ask them, what are the predictions that you have? For example, I will have pain in my ears, I will get headache, I will have to stay in bed for a whole day to get recovered from this. And then you ask them to quantify the actual predictions that they have, because you want to test them. This is an experiment, so you want to see whether these come true or not. So how much pain you think you have? For example, this person 80%, 100% is the maximum. How much headache? 90%. How long you have to stay in bed to get recovery from this? 3 days. And then each day that they use the Hoover, they take a log of what was the actual percentage that they observed, the data that they collect. And there is often a discrepancy between the data that they collect and the predictions that they had. And then this is going toward the learning part of their cognitive behavioral therapy, that the predictions that they have may not necessarily be true, and that helps them to move toward more wanting to change those negative predictions, because they are not entirely true, and they have proof of that themselves during this cell experiment. I stop here.